Good afternoon, everyone. My name is Greg Tashin. I am very much looking forward to joining this group next Monday on the 19th, and just wanted to take the next 20, 30 minutes to provide some context and framework for our discussion on Monday. The conversation is going to center around complex interventions in learning health systems. And I wanted to use this time today to go over the following learning objectives. The first being to learn the characteristics of complex interventions, to really understand what a complex intervention is, particularly within the framework of a learning health system. And two, to understand the purpose and structure of process evaluations of complex interventions. So the next slides are going to go over these objectives, and then we're going to conclude with two examples from ongoing trials that can provide some way to understand and wrap your heads around complex interventions and how we evaluate them. So I think it's important to start with a definition, or at least a construct for a complex intervention. And a complex intervention can be somewhat difficult to define in that there's not a single definition or characteristic of a complex intervention. Rather, it's defined by the constellation and consideration of a number of different factors. And these factors include the number of interacting components, the number and difficulty of behaviors required by those delivering or receiving the intervention, the number of groups or organizational levels targeted by the intervention, the number and the variability of outcomes in the study, and finally, the degree of flexibility or tailoring of the intervention permitted within the study design. So with that framework, I wanted to provide 4 examples that hopefully will serve as a springboard for our conversation on Monday. In each of these are 4 examples of studies and interventions that could be conducted within a clinical trial, and they vary with respect to the simplicity and the complexity of the intervention, taking all those factors on the previous slide into account. And the first intervention is simply a drug trial. So you have drug X comparing the effectiveness of drug X to drug Y, and doing this in any without consideration of any particular framework of a learning health system. The second is vaccine administration, taking COVID-19 vaccine as the example. And the third is a behavioral health behavior intervention using counseling. And the final intervention is surgery. So each of these studies and each of these interventions vary with respect to their complexity. And each of the 5 factors are listed on the left side of the screen, and a proposed checklist of each of the 5 factors is included on this slide. There's certainly discussion that can be had about the degree to which each of these components is relevant to these 4 different interventions. We can continue that discussion on Monday. But I would propose as a way for initiating this conversation that a phase 3 trial of drug X, especially if it's compared to a placebo, would be the simplest intervention in that there are very few interacting components except for the patient characteristics and the disease severity. And that there are really a limited number of groups or organizations targeted by the intervention, and often you have a primary outcome with some secondary outcomes considered, and that there's very little to no flexibility in how this intervention is administered. The COVID-19 vaccine, on the other hand, is a rather simple intervention in a very complex environment that does include a number of interacting components, including the acceptability and the participation of any particular group of individuals in the trial or in the real world effectiveness studies, and that there is quite a lot of behaviors required by those receiving the intervention to participate, and that there are more groups and organizational levels involved than in the previous example of the drug trial. Medication adherence, which is the counseling example, certainly has a high degree of complexity with respect to all of the factors, as I would propose surgery does, with the possible consideration of a limited number of groups and organizational levels that are targeted by the intervention, as the target is typically the individual patient. So we can continue this discussion on Monday. And as the second part of our seminar on complex interventions, I wanted to propose the process by which we evaluate the intervention itself. And typically in comparative effectiveness studies or efficacy studies, we're very used to seeing reports of the efficacy of the intervention using the output from regression models, and you have the point estimate and confidence intervals to get an understanding of the effect of the intervention in the population on the outcome of interest. However, there are some resulting knowledge gaps when we look at these reports of efficacy in isolation, particularly as it relates to complex interventions. These reports of efficacy do not provide any understanding of how an intervention might be replicated in the specific context, or how it might differ in different contexts. And this has implications for reproducibility. Therefore, the purpose of a process evaluation of the complex intervention is really designed to address three key factors, and that's the what, the why, and the how. So specific ways in which a process evaluation does this is by assessing the fidelity and the quality of the implementation of the intervention. It can provide insight into the causal mechanisms behind the intervention. And finally, and importantly, identify the contextual factors associated with variation in the outcomes in the population of interest. So the key functions of these process evaluations really emanate from those considerations. And the process evaluation is something that starts before this study is actually initiated, in that it has to be designed before the implementation of the intervention. And then as the intervention and as the study proceeds, the process evaluation is there to provide insight into whether the intervention was implemented as planned, and then how it was implemented. Much of this work, depending on the study design, does involve some qualitative aspects, but it can also involve very quantitative ones as well. It very much varies depending on the design of the study and the intervention at hand. The second function of a process of evaluation is the mechanism of impact. And that's really getting to the causal mechanism, in that how does the intervention produce change? And finally, is the understanding provided about the context. And that's the question of how does the environment affect the implementation and the outcomes in the study. It can be really thought of as identifying some of the barriers and facilitators to the effectiveness of the intervention. And to me, one of the most striking examples of this is the implementation of a COVID vaccine, and that you have a simple intervention in a complex environment in which the infrastructure of how the intervention or how the vaccine is administered is critical. And then you have all the behaviors and how those behaviors differ among different groups within the population. So everything that we're considering with this complexity needs to be really considered in the process evaluation designed to evaluate it. So I wanted to provide two examples of studies that my group is conducting right now. One is a comparative effectiveness study in a large, will ultimately be a learning health system that includes surgical interventions. And then the second is in a large multi-center trial of a multi-component intervention to change health behaviors to prevent kidney stone recurrence. The first example, which is a comparative effectiveness study, is being conducted in the Pediatric Kidney Stone Care Improvement Network, or PKIDS. And investigators in PKIDS are comparing the effectiveness of 3 standard of care surgical procedures to remove kidney stones in children, adolescents, and young adults. These procedures have all been in clinical practice for over 20 years. And they, at face value, appear very simple, but we'll get into the complexity. Those 3 procedures are ureteroscopy, which is an endoscopic procedure, which a small scope is inserted into the ureter and the kidney to remove stones using a laser to break up the stone into smaller fragments. The second is called shockwave lithotripsy, and that's the so-called blasting the stone, which is not an invasive procedure, but rather uses shockwaves that are generated outside of the body and focused on the stone, that then turns that stone into small particles that then pass spontaneously down the ureter and are then eliminated through voiding. And the final procedure is called percutaneous nephrolithotomy, or PCNL. And that's a minimally invasive procedure in which a small incision is made in the flank. It can be anywhere from a couple millimeters to a centimeter or so. And a scope is inserted directly into the kidney to remove the stones through a sheath. And this study is being conducted because there is a very poor evidence base regarding the effectiveness of these interventions in children. And because stones, while not a rare disease, are an uncommon disease that is increasing in incidence across the United States in children, the study is being conducted at 26 sites, all of which are members of PKIDS. And this certainly adds to the complexity of the intervention. The complexity of surgical interventions really comes from the context in which that surgery is performed. And surgery is not like a medication in which that same medication is administered at CHOP as it would be at Seattle Children's, but rather there is inherent variation in how a surgical intervention is delivered. So ureteroscopy at CHOP might be very different than ureteroscopy at Seattle Children's. Also, surgery exists within a larger environment that is influenced by many different factors. And those include surgeon characteristics, the hospital characteristics, such as availability of equipment, and various resources in the perioperative environment. And it's also determined by access factors of the patient, as well as patient characteristics. And as mentioned at the beginning, within a particular surgery, there are technical factors that differ within an intervention. And all of these different factors within the larger environment can influence the choice of the intervention, and it can influence the choice of the outcomes, which in the setting of the PEDSnet study is a clinical outcome of stone clearance, which is the removal of stone determined by radiographic imaging postoperatively, and has been associated with stone recurrence and recurrent visits to the ER. And then the novel aspect is the patient prioritized experience that's largely captured through longitudinal measurements of patient reported outcomes, primarily done through patient selected and prioritized PROMIS measures. So because of the complexity of surgical interventions, it is necessary, particularly in an observational study such as PEDSnet, to be able to characterize all of the different components that could influence both selection of intervention as well as outcomes, and then be able to understand how the intervention is being implemented, some of the causal mechanisms behind it, and to understand how the larger environment could impact the implementation of the surgical intervention and also the outcomes. Therefore, we've employed a really robust characterization of all of these different groups within PEDSnet. And as a ultimate learning health system, we want to be able to generate knowledge within the delivery of routine clinical care, and then upon analysis of those results, be able to apply that knowledge back into care so that outcomes can be improved directly at the 26 sites within the network by applying the knowledge of the most effective interventions and, importantly, how each intervention is administered. So to that end, we've developed a tightly integrated means of delivering the care as it exists within clinical care, but then being able to assess outcomes in a standardized way, yet embedded within the framework of clinical care. And that's done through a standard postoperative imaging that occurs at 6 weeks after the intervention, after the surgical intervention. And those are been accepted as standard clinical measures at all 26 sites. And then in order to capture the longitudinal assessment of the patient experience, we're using electronic dissemination of the patient-reported outcomes at baseline, and then also at 1, 3, 6, 9 weeks after surgery, as well as 3 months. And for the sites that participate in PEDSnet, we're performing an ongoing surveillance of ED visits, hospitalizations, and recurrent surgeries that occur following the initial surgical interventions. So I wanted to provide some examples of the process evaluation that we're using to assess all the different components of the 3 surgeries. And the first example is the CRF, which we're calling the surgeon questionnaire. And this assesses factors before the initiation of the study that provide some baseline information on each of the over 100 surgeons who are participating in PEDSnet. And this questionnaire assesses factors that we believe are going to be important for understanding the outcomes, as well as how to generalize these results. And some of these factors include the years in practice following training, the fellowship training, or in some cases, fellowships in multiple subspecialties. And then also the weight to which any individual surgeon places on particular patient characteristics when making surgical decisions. The questionnaire also assesses the degree to which an individual surgeon uses different clinical decision aids or nomograms when making surgical decisions or counseling patients preoperatively, and whether or not they refer patients to kidney stone surgery or for kidney stone surgery, or whether they're specialists in that particular type of surgery. And then finally, because there could be and there are surgeons who do have ownership in some of the equipment used in surgery, we wanted to be able to have this understanding and this knowledge at the beginning of the study so that, again, we can understand the context in which care is delivered. We've also obtained information on the larger health system in which each individual surgeon practices. And this questionnaire assesses, yeah, I actually can't even see it because I have the screen sharing tab at the top. But it assesses the volume of individuals with kidney stones seen at that hospital on an annual basis, the payer status of the majority of patients with stones, again, the incorporation of fellowship programs, and the ownership of particular equipment and the access to that equipment. And this, I think, well, this is the case report form that is now integrated in Epic at a growing number of sites within PKIDS. And this is the critical portion of the process evaluation that allows us to understand how a particular surgery was delivered. So ureteroscopy is not ureteroscopy. It's a particular procedure with so many different subparts that has so much variation across health systems and across surgeons. So this CRF captures that variation in how ureteroscopy, as well as shockwave lithotripsy and percutaneous nephrolithotomy were delivered. So it includes the type of equipment, the type of ureteroscope, whether or not an ancillary device called an access sheath was used, whether a particular type of wire, which is designed to provide additional safety, was used, the irrigant used, and the important laser type and the method of lasering used to remove the stones, all of which could very much affect the outcome. And then finally, the number of times that a ureteroscope was passed, which is hypothesized to impact the patient experience postoperatively. And then finally, whether a stent was placed at the end of the procedure. So I illustrate these to demonstrate how a seemingly similar intervention, to use an example of shockwave lithotripsy or ureteroscopy, is in fact a multi-headed beast, both within the procedure and in the larger environment where it's administered. And in order to be able to generalize those results and ultimately apply the knowledge back into clinical care, we have to understand how it's administered and the context in which we generated those results. The second example that I'll give here and where we'll conclude is in the prevention of urinary stones with hydration trial. So this is an NIDDK funded trial that is being conducted at 6 sites in the United States, with CHOP and PEN being one. And this study, or this trial, is designed to test the efficacy of a multi-component intervention designed to maintain a high fluid intake in order to prevent kidney stone recurrence. And this is being conducted in both adolescents and adults, which is the first trial in stones to include both children and adults. And this is the construct of the study design and the intervention, in which participants are randomized into a control arm. These participants receive just standard of care advice to drink more water to decrease stone recurrence, and they receive a smart water bottle. The second arm is the intervention arm, in which these participants receive a smart water bottle. They also receive a specific prescription of how much more water they should drink each day in order to decrease their risk of stone recurrence. And then in order to help maintain that high fluid intake, all of the intervention arm participants receive a daily financial incentive that is operationalized through Way to Health. And for those participants who are able to maintain a high daily fluid intake, they continue on only with the financial incentives that are gradually tapered over the course of the 2-year study. And then for those participants who do not maintain a high fluid intake, they flow into coaching using a design called structured problem solving in order to overcome those individual barriers to fluid intake. And I wanted to focus on the structured problem solving component here because I think that's where the complexity of this multi-component intervention really is. So the primary endpoint has already been stated, I believe, which is symptomatic kidney stone recurrence, and that's defined by stone passage that's either observed or captured by the study participant, a surgical intervention for a symptomatic stone, or a procedural intervention for an asymptomatic stone. So the components of the structured problem solving is 6 steps. One is to identify the problem, and this is by the participant, not by the coach, to list all possible solutions, to assess the feasibility of each solution. Number 4 is to select the most practical solution. Number 5 is to create a plan to implement this solution. And then number 6 is to revisit at a later time the progress and success in implementing this solution. So this type of intervention has been used successfully in improving medication adherence and self-management. And I'm going to go over, similar to how we did with PKIDS, the way that we're assessing how this intervention is being implemented and some of the qualitative aspects of the intervention, or the process evaluation, rather. So these are case report forms that indicate simply the stage of the structured problem solving, whether it's the first session, whether it's a feedback session where they're reviewing progress, whether they need to reinitiate the whole approach of structured problem solving from the beginning if there has been inability to, or if that identified solution just didn't work and we have to restart it. Again, here's some of the more qualitative aspects in some way of how the encounter was classified. Is it building rapport? Is it going over the logistics of how they're going to implement the study? Are they providing validation of the participants' progress and identified solutions? And here's some of the way that we're assessing what was actually administered. It's unlike a medication where it's just a simple checkbox. We have to know the degree to which participants were touched by structured problem solving, and if they weren't touched to the full extent, why they weren't. So this is where that is indicated. And the means of contact. And then the duration of the intervention per participant and per contact. And then finally here is the fidelity assessment. And I think this is one of the most important parts of the structured problem solving, in that it assesses each of the components of structured problem solving, but does so in a qualitative or semi-qualitative way to make sure that the coach is creating an environment in which the participant can develop these solutions in a very safe and in a very safe space and in a supportive way by the coach. And each of these rows here is a way in which the fidelity assessor, which reviews these encounters in the pre-recorded sessions with the individual participant, with how they actually operationalize this. So this is done for a sample, not all of the participants who reach structured problem solving. So I hope that the last 30 minutes or so provided a springboard for our conversation on Monday. And I wanted to leave you with this. A complex intervention is one with multiple different intersecting components. And part of implementing a complex intervention is understanding the what, the how, and the why of that intervention. And I look forward to discussion of the overall concept as well as any particular questions that came out of these examples and any of the readings that you might have. But I hope you have a great weekend and look forward to Monday. Thanks so much. Bye.